Okay. Good. Yeah. Okay. Namaste, everyone. Thank you so much for joining us today. Here we are in the 36th webinar of Nepal Mental Health Research webinar series. So welcome back to the webinar series in a new year with a new topic. So before moving towards the webinar content or the title, I would like to introduce myself. I am Binita Acharya, working as a research officer at TPO Nepal, and I'll be moderating this webinar on behalf of our team. And for today, we also have Ritika Singh, who is research consultant at George Washington University. And we also have Dr. Brandon Pott, who is professor at George Washington University. So if you are joining for the first time, these webinar series are being conducted by TPO Nepal under the RESAVE project, focusing on the capacity building of early and mid-career Nepali mental and behavioral health researchers. So it basically focuses on the title and area of researches for the capacity building and for the motivation or for the support of early and mid-career researchers for their growth in research careers as well. So as you can see in the screen, the title of our 36th webinar, which is Non-Inferiority Trials in Global Mental Health, a case example of a common elements treatment approach, CITA, in Zambia. And for today, our speaker is Dr. Jeremy Kane. After some minutes, Dr. Brandon will be introducing our speaker. So before that, we have some couple of reminders which we do share in our each webinar. So the first thing is the webinar is being recorded. The main motive of recording this webinar is to share the webinar recording. So basically the materials to all the registered participants for their ease to understand and go back to the title of interest as well. So if you haven't registered the webinar yet, please do register the webinar. The webinar registration form can be found in the TPO social media pages as well. So this is a reminder to fill the registration form so that it will be easier for us to share the materials to the registered participants. This another reminder is related to the webinar structure. The duration of the webinar is an hour, which means 6 to 7 Nepal time. So after this introductory session, we will be having the presentation of our speaker for 30 minutes, where we do not interrupt the speaker in between that time durations. After that, we will be having 10 to 15 minutes of Q&A sessions, or it may last to 20 minutes as well, depending on the content or depending on the questions you have as audience. So at that time, it means that we will be asking the questions, or the floor will be open for the queries in that Q&A sessions, rather than interrupting the speaker in the presentation as well. So after that, we'll wrap up the webinar with a summary sentence or summary feedback or anything from our speaker as well. So the last reminder is related to the feedback form. As I already mentioned, that this webinar series focuses on the capacity building of early and mid-career researchers. We have modified the webinar based on the structure or based on the topic related to the feedback or suggestions from our audiences. So if you have any kind of suggestions in the topic or a structure, you can write us in the feedback form as well. We do share the feedback form with the webinar materials or in the chat box later on as well. And just information that these monthly webinars are conducted on and are being conducted in the third week of every month, except the Dase and TR break. Invitation email will be sent out with the speaker details and dates to the network members, and we'll be sharing all the related announcement and information or the registered form in the social media pages. So for more information, you can follow our social media pages or email us in our Amazon email address, which is mentioned in below, for any kind of information related to the webinar as well. So for now, for the introduction of Dr. Jeremy Kane, I would like to request Dr. Brandon Code to go ahead. Thank you.
Thank you so much, Benita. And I was just thanking Jeremy for joining us so early in the morning. And good afternoon, I guess good early evening to all of you in Nepal. So I'm so excited because Jeremy Kane has really been kind of a friend to Nepali research for many years now. Did a really important study after the earthquake in 2015, has contributed to collaborate and support many members of our research team. He's also just a excellent communicator about mental health research strategies. He's, in addition to supporting our team, supported colleagues in Uganda, and it's always a pleasure to hear him speak. I always learn something new. I'm really excited about this topic today in terms of non-inferiority trials because it's a good way for us to think about what are the best strategies, and there may be more efficient ways to do some of the studies we want to do in global mental health, especially when we're trying to replicate effects in different settings. In terms of Jeremy's professional bio, he is a psychiatric epidemiologist with research interests in global mental health, substance and alcohol use epidemiology, and adolescent health. His research investigates mental health and substance use problems among populations affected by violence and HIV in low and middle income countries, and explores the impacts of culture and migration on mental and behavioral health among refugee and immigrant populations living in the United States. His research program is implemented in collaboration with academic institutions, non-governmental and international organizations, and government agencies. And he has kind of three main goals in his work: measuring the prevalence, patterns, and correlates of mental health, alcohol, and substance use problems in these populations, developing and validating innovative methods for reliable and valid measurement of mental health, alcohol, and substance use problems, and ultimately developing, adapting, and testing interventions to address these problems through randomized controlled trials and other implementation studies. With that, I'll turn it back over to you, Benita.
थ्याङ्क यू डक्टर ब्रान्डन मेरो एउटा रिमाइन्डर चाहिँ फेरि के छ भने हाम्रो नेपाली स्पिकिङ हुनुहुन्छ स्पिकर्स हुनुहुन्छ जो अडियन्सेसहरू उहाँहरूलाई चाहिँ यदि क्वेसन्सहरू चाहिँ नेपालीमा सोध्न कम्फोर्टेबल हुन्छ इङ्ग्लिसमा भन्दा त्यहाँ लेख्नुभन्दा भने चाहिँ हामीले ट्रान्सलेसन पनि गर्छौँ क्युएनए सेसनमा सो पछाडि चाहिँ आफ्नो क्वेसनहरू चाहिँ रेडी बनाएर राख्दै गर्नुहुन्छ बिचको प्रेजेन्टेसनको टाइममा यो भन्न छुटेँ रहेछ अघि थ्याङ्क यू एन्ड डक्टर केन द फ्लोर इज योर्स
Oh, thank you so much. So let me share my screen if I can. Okay. All right, hopefully you guys can all see the screen and hear me okay. Let me.
Jeremy, it's still in the.
There we go.
Yeah, perfect.
Can you see it? Is that better, Brandon? Okay. Well, thank you so much for the kind introduction, Brandon and Benita. Truly my pleasure to be with you today and part of what's really been described to me as this really incredible seminar series that you've had. Number 36, I think, is this one, which is really amazing. So well done to you guys for doing this. I think it's a really, really cool thing and a unique thing in our field. I hope that our discussion today will be interesting and useful to you. On a personal note, as Brandon alluded to, I know that many of the attendees here are from Nepal, and so very warm wishes to all of you. I've spent a good amount of time in Nepal, both for work, but also professional, but also personally. It's where my wife and I went on our honeymoon, and so it's a very special place for me. And I hope to. It's been a long time, and I hope to make my way back there very soon. So, so today we're going to talk about a specific type of randomized controlled trial design, the non-inferiority trial design, and its use in global mental health research. So I'll be talking about that, plus I'll give you an example of a very recent study that our team conducted in Zambia, which is a country in Southern Africa, where another place I've done a lot of work, over the years. So the lecture is about 30-ish minutes. We'll leave some time for questions and discussion, of course. I split the lecture into 3 parts. The first part will be a brief overview of randomized controlled trials in general, what they are, why randomization is so important, how they've been used in global mental health, really kind of a focus on more of that classic superiority randomized controlled trial design. The second part will then introduce the concept of the non-inferiority design and what differentiates that design from sort of the more classic superiority one. And then finally, we'll conclude with an example from Zambia, as I mentioned. And then I also listed here some like suggested readings if you're particularly interested in the topic. The first is by Piaggio and colleagues from their JAMA paper. This is the official consort guidelines for designing and reporting results from a non-inferiority trial. So it's a really nice place to kind of start to get a sense of what are the features of non-inferiority trials. That second paper by Mowry and colleagues is from a New England Journal of Medicine article. It's a really nice again overview on non-inferiority RCTs and especially the challenges that can come along with them, and there are challenges for sure. And then finally, there's a paper that we listed that I think we sent out as well, but happy to send all of these out to the group. That paper led by my colleague Caleb Figge at Johns Hopkins, which is the protocol methods paper for the non-inferiority RCT from Zambia that I'm going to be talking to you about today. The paper with the results from that trial is not yet published. We're actually writing it up now. You guys actually this evening are going to be one of the first audiences to hear about results from that trial, which is hopefully very exciting for you, exciting for me to share. Again, happy to share these readings afterwards and also provide a fuller sort of reading list for those who are interested. Okay, so part one. So let's just talk a bit about RCTs in general in global mental health. I think this might be somewhat of a review, but I think important to kind of go through it, right? So this is a slide that I use early in the course that I teach here at Columbia on epidemiologic methods. And one thing to keep in mind is that all of our study designs in public health and epidemiology more or less have the same goal, and that is to enable us to identify causes, to enable us to establish a relationship between an exposure and an outcome. Now, the nature of the exposure and the outcome can vary quite a bit from one study to the next and one study design to the next. But for the most part, that is our goal in epidemiology. And much of the work that we do to identify causes includes comparing people with and without an exposure of interest. And so study designs are tools for us to try our best to compare comparable groups so that the group without the exposure is comparable as much as possible to the group with the exposure. And again, this is true regardless of the study design, be it randomized controlled trials that we'll talk about today, or some of the other types of studies that you may know about, all right, like cohort studies, case control studies, survey prevalence studies, et cetera. The difference between study designs is often how we go about trying to make exposed and unexposed groups comparable. And so why is comparability so important? It's critical really because in order to assess a causal association between an exposure and an outcome, we want, or should we say we need comparability. And this is especially important when the exposure of interest is a treatment or an intervention, right? We want that causal evidence that the treatment or intervention is changing or associated with that outcome, right? So what do we mean by comparability between groups? We mean that an exposed group, the group that has the exposure of interest, and the unexposed group, the group that does not have the exposure of interest, are comparable if they have equal distributions of all causes of the outcome other than the exposure of interest. And so this is what that looks like graphically. These two groups of people with the exposure on the one hand and without the exposure on the other hand would be considered appropriately comparable because there are equal distributions of all causes of the outcome in each group other than the exposure that we are interested in studying. This is a simulation of what we call the counterfactual, right? Of what the same group of exposed people would be like if they did not have that exposure. The only difference between these two groups is that one has the exposure that we're interested in, the other one does not. Otherwise, they are the same, right? And in a classic randomized control trial, the exposure typically is our intervention or our treatment. So how does the concept of comparability relate to randomized control trials, right? It has to do with the nature of randomization, which is obviously integral to the RCT design. So perhaps the strongest tool that we have to increase comparability between exposed and unexposed groups is to randomize study participants, right? That is, assign whether they receive the exposure or not, assign whether they receive the intervention or not. So randomization as a process is a way to try and buffer the study from biases that may be introduced by the researchers into the assignment process. It's a method for assigning exposure status to research study participants, and it gets us closer than any other method that we currently have in science to approximating the counterfactual. And so here are the basics of an RCT definition. An RCT is a prospective study that uses randomization to compare the effect of an exposure on an outcome of interest. RCT participants are randomly assigned to receive or not receive the exposure of interest. In RCTs, we typically refer to the exposed group as a treatment group because our exposure in RCTs is often an intervention of some sort. And we refer to the unexposed group as a control group that does not receive the exposure or intervention. So by randomly assigning the exposure, instead of purposefully assigning it, we increase the comparability between the treatment group and the control group on both known and unknown factors that might cause the outcome. Often we refer to this as confounding in epidemiology. And so really at its core, randomized controlled trials are a very strong way to control for confounding. So here's just a figure of a classic randomized controlled trial superiority design. The exposure, which again for us is typically some sort of mental health intervention or treatment, is randomly assigned to study participants. So you have an exposed group and you have an unexposed group, and then everyone is followed to determine who develops the outcome, or depending on the treatment and the design of the study, we often look to see who has reduced levels of mental health symptoms, all right? That's usually what we're looking for in a mental health randomized controlled trial. Is there a difference in change in mental health symptoms between those who received the exposure, who received the treatment, and then those who did not, those who were in the control group? So here are just a small few of some major randomized controlled trials done in our field of global mental health. A notable one done in Nepal, of course, featuring potentially some people who are on the call right now, where they trialed Problem Management Plus, PM Plus, a few years ago. The upper right-hand box, the Common Elements Treatment Approach, or CETA. I'll talk more about CETA in a minute, an intervention I've worked with quite a bit in my own research, especially in Zambia. This paper was a trial they did of CETA in Thailand. The bottom left, going way back to what some may say was one of, if not the first kind of big randomized controlled trial in our field, group interpersonal therapy, IPT, in Uganda. That was back in 2003. And then much more recently, lower right-hand corner, EASE, the Early Adolescent Skills for Emotion Intervention for Youth. And this one was in Lebanon, an RCT that I was lucky enough to have a chance to help a bit with when it got to the analysis stage. And of course, there are many, many more examples of sort of these classic superiority randomized controlled trials in global mental health. And so when you look at these superiority randomized controlled trial designs, what are the essential considerations, right? This is not a comprehensive list, but this is sort of, I think, the bare minimum of what you need to consider. Of course, key is choosing your primary and secondary outcomes. Are we focusing on depression or anxiety or PTSD or substance use or stigma or a combination of these? What do we hope that our intervention will address? What is the population of interest? And what are the eligibility criteria? Are we focused on adults? Are we focused on adolescents? Are we focused on trauma survivors? Are we focused on people living with HIV, et cetera? How are we going to recruit people into our trial? This is a really important consideration for generalizability of findings. Are we recruiting from medical clinics? Are we recruiting from the community, right? That has an impact on what you can say about who your findings apply to. Sample size, of course, is key. Is our sample size sufficient for evaluating a difference in the primary and secondary outcomes between the treatment groups in a randomized controlled trial? Is your sample size big enough to do secondary subgroup, or what we call moderator analyses, which are really important? So your sample size consideration is key. Of course, what are your exposures? What are the intervention and control groups? What do they consist of? What is the intervention people are getting? What is the control condition, right? Defining that very clearly. And then the follow-up period. In our work, oftentimes we have relatively short follow-up periods. If you read trials in our field, usually 6 months after a baseline, sometimes up to 12 months. But I think, I think one of the major limitations of our intervention research generally is that we don't know really what happens to people long term after receiving an intervention. But that's a topic for another lecture. Okay, but these are kind of the key considerations of classic randomized controlled trial designs. Again, this probably was a bit of a review. You probably are familiar with these. And so the trials that I mentioned a few slides back in global mental health, right? They all had to think about these elements when they were designing those studies. But a main thing I wanted to highlight that they all had in common was that they were indeed superiority randomized controlled trials in which the goal was to test whether an intervention, PM plus or CETA or IPT or EASE, was superior to a control group. And the control groups that were included in those studies were relatively weak, right? Usually a waitlist control group, a standard of care control group where the standard of care was admittedly not very good, or low intensity control interventions. And I don't mean to imply at all that this means the study designs were weak themselves, not at all. Just that for these trials, the most appropriate control group choice tended to be what we would consider to be a sort of weak control. Okay, and those superiority trials are really important for establishing whether those interventions, CETA, PM plus, EASE, IPT, et cetera, are effective, right? So they are actually very vitally important as sort of the first step. But what if we wanted to go a step further? And so here in part two, we're going to get into a little bit of a twist on the RCT design and really dive in a bit more into the non-inferiority trial design, why we might want to use them, and if we do use them, what are some important design considerations that are distinct from the classic superiority trial? Okay, first, so when would a non-inferiority design be appropriate? So non-inferiority trials are used for determining if new treatments or interventions are no more than a predetermined amount less efficacious than a current standard treatment. This predetermined amount is what we call the non-inferiority margin, and I'll talk more about that in detail in a minute. So these trials are typically used when you already have in place an accepted evidence-based intervention, and then you want to test whether a new intervention is at least almost as good as the existing one. These trials can be particularly helpful when you want to test a new treatment that provides a benefit to the client, the patient, or the funder, such as a safer or more cost-effective treatment option. So frequently you'll see non-inferiority trials done when a new intervention is thought to be less toxic or less invasive, if you're talking about drug trials, compared to the existing evidence-based standard treatment, or more in line with our mental health work. if we have a new intervention that is somehow less expensive than an existing one. For example, if we have a new intervention that we think can be conducted remotely instead of in person, and so it costs less, or if we have an intervention that we think will be less time consuming than the current one. For example, if it includes fewer therapy sessions than the existing evidence-based standard, right? So to put it sort of simply, in the previous randomized controlled trials that we mentioned featuring IPT, CETA, PM+, and EASE, those trials asked, is intervention A superior to or better than intervention B, which was the control group in those situations? Now with non-inferiority trials, we're asking, is intervention B non-inferior to intervention A? So it's a somewhat subtle, but a really important distinction between what we're asking in the superiority randomized controlled trial and in these non-inferiority randomized controlled trials. So this slide is very similar to the previous one I showed you on the essential design considerations for superiority randomized controlled trials. All of these considerations are still really important in non-inferiority trials, right? Outcomes, population and eligibility, recruitment sample size, intervention and control group, follow-up period. They're all still really important here. But now we have these two additional important considerations, and there are more important considerations as well. But these are the two that we really need to focus on, and that are I think the most important. The first is sort of the number of arms you want to have in the trial, whether you want to include 2 arms or potentially 3 arms. And then the other consideration that's really important is setting that non-inferiority margin. Okay, so first let's talk about this decision of having 2 or 3 arms in your non-inferiority trial. So consider these 3 possible groups in an RCT, right? So group A is your current evidence-based standard treatment, right? Group B is your new experimental treatment, right? And then group C is a no treatment or a placebo control group, right? When you talk about kind of drug trials, you talk about a placebo sort of no treatment control group. Now, in a 2-arm version of a non-inferiority trial, we would only include groups A and B, right? We would not include that no treatment or placebo control group. And our main study question would be, is group B, this new experimental treatment, non-inferior to group A, the current evidence-based standard? Okay, so that's how you do it if you do a 2-arm non-inferiority trial. The other way to do it is a 3-arm non-inferiority trial in which we include all 3 of these groups. And there's a bit of a twist with this design in that we actually have 3 questions that we would ask in this sort of setup. Again, similar to the first one, we would ask, is group B, the experimental treatment, non-inferior to group A, the current evidence-based standard? But in addition, we would have 2 more questions that we're interested in answering. First, is group A superior to group C, that no treatment control group? And then separately, we would ask, is group B superior to that no treatment control group? So I wanted to share some, sort of perspectives on this decision, and I'll share in a minute what we did in our CETA non-inferiority trial in Zambia. So, and I'm happy to share these papers too, which are also really nice resources in this topic. So according to Emerson and colleagues, in a gold standard non-inferiority trial design, a 3rd arm would be included as a placebo, included to allow a test for assay sensitivity, which ensures that the treatments being compared for non-inferiority are not ineffective themselves. So this makes some intuitive sense, right? If you only include treatments A and B without the placebo or no treatment group, you really can't guarantee necessarily that either or both of A and B would have been superior to C. All you're doing is comparing them to each other, right? So we don't know really how they would do against this no treatment placebo control group. So from a scientific perspective, having 3 arms is usually a stronger design. That way, there is both a non-inferiority comparison between new treatment B and current standard treatment A, as well as those superiority comparisons between A and C, and also between B and C. But there's more perspectives on this, right? So from that Mowry and colleagues paper I mentioned at the beginning from New England Journal of Medicine, they write that even if there is no placebo group, an implicit superiority comparison between the test treatment and placebo underpins the non-inferiority trial. 3-group studies that include a placebo group may allow that explicit comparison, but practical or ethical reasons often preclude randomized assignment to placebo, and instead historical data must be relied on for the placebo comparison. So what these authors are saying is that while, scientifically, having 3 arms with that placebo no treatment control group would be ideal, it may not be ethical to do so. So for example, it may be unethical to have a no treatment control group and withhold treatment from people if you know that there is something that is in existence in that population or in that setting that is already known to be effective. So instead, what they are saying is you can do a 2-arm trial and then just sort of benchmark the effect sizes that you find in your trial against what has been found previously in the literature from superiority RCT. So that's sort of a bit of a compromise approach if a 3-arm RCT is not considered ethical. So this clearly could be a very lengthy discussion, but I wanted to just highlight for you, if you're in a situation of designing or working on or just reading about a non-inferiority trial, this is a key consideration that you should think about when you're reading them. Why did the researchers decide to do 2 arms instead of 3 arms, or vice versa? Okay, so choosing to have 2 or 3 arms, very important. Perhaps even more important, some might say, the most important decision of designing a non-inferiority clinical trial is choosing this margin of non-inferiority. So the non-inferiority margin is defined as the largest clinically acceptable difference between the current evidence-based standard treatment and your new experimental treatment, right? The question is, how do we know if a new experimental treatment truly is non-inferior to the current standard? And who gets to decide that, right? So if we say, for example, a current standard treatment A reduces depression by 15%, and new experimental treatment B reduces depression by 10%, that would be a non-inferiority margin of 5%, right? Do we say, okay, we think treatment B is non-inferior to treatment A? Do we think that gap, 5%, is close enough to consider B to be just about as good as A, or do we still think that's a meaningful difference? So obviously, the implications of this decision on that non-inferiority margin are really substantial for how you interpret the results of your RCT. So often when you see results of non-inferiority trials, you see them displayed this way, graphically, with a shaded area that represents the non-inferiority margin. This graph, by the way, on the screen is the example straight from that Piaggio paper in JAMA describing the consort guidelines for non-inferiority trials that I very much, again, encourage you to check out if you're interested in this topic. They go into a lot of detail explaining some possible outcomes and ways that these non-inferiority studies can turn out. I'll show you a version of this in just a few slides when we get into our results from the CETA trial. But I just wanted to highlight a few things here for you. Again, non-inferiority trials, you can take an entire course on, a whole semester-long course. So we're just giving you some highlights here. All right, so let's look at the graph. So thinking about effect sizes, the way that this graph is laid out, if an effect size from the trial is in this graph, the effect size is the treatment difference for an adverse outcome, right? So in this example, if that effect size is less than 0, it favors the new experimental treatment, right? So you can see that red circle at the top on the left-hand side, right? So effect sizes that are less than 0 mean that your new treatment is better. If, on the other hand, the effect size is positive in this situation, higher than 0, then it favors the current standard treatment. It means that the new experimental treatment did worse. Now, again, the shaded blue area here to the left of that delta symbol at the bottom of the graph is what we call our non-inferiority margin. And so if your effect size falls to the left of that delta in this shaded area and its entire 95% confidence interval around the effect size is within that shaded area, at minimum, we would be able to say that the new treatment is non-inferior to the standard treatment. So we're going to walk through a few ways that these trials can turn out. So first, you may run a trial like this and you get an effect size like option A here, right? So here, if you look at option A circled in red, that black box there represents the effect size itself. The bars on either side of it are the 95% confidence interval around that effect size. You can see that the effect size and the entire 95% confidence interval are to the left of 0. This indicates that not only is the new experimental treatment non-inferior to the standard treatment, but actually the new treatment is superior to the current standard treatment, right? So this is a rare outcome in a non-inferiority trial, but it can happen, and this is what it would look like if it did. But this is usually what we're looking for in these trials, right? Results B, C, or D. So here we see effect sizes that fall within the non-inferiority margin, right? This blue shaded area. The effect size is in the shaded area, and importantly, those bars, the 95% confidence interval around the effect size, the entire thing also falls within the shaded region. So results like this, we would infer that our experimental treatment is non-inferior to the standard treatment, right? But you'll see that, at least for 2 of these, the confidence intervals overlap with 0, meaning we can't say the experimental treatment is superior to the standard treatment, but we can at least say it's non-inferior. So here's another possibility. There's lots of possibilities with these trials. Here, the effect size and its entire 95% confidence interval is outside the non-inferiority margin that we set, right? It's all the way to the right of that blue shaded region of that delta symbol. And so here we would infer that the new experimental treatment is in fact inferior to the standard treatment. It is significantly worse than the new experimental treatment, and we would likely not recommend using it. And then finally, we have sort of this, like the possibility of a murky, it's kind of muddled result. So it's possible that in these trials, and this actually happens with some regularity, if you read the literature, it's possible that you come up with an inconclusive result. So here we have effect sizes with 95% confidence intervals that overlap that dotted blue delta line, right? They overlap the non-inferiority margin. So partly they are within the non-inferiority margin, and partly they are outside the non-inferiority margin. So we refer to this as inconclusive. We can't definitively say one way or another if the new experimental treatment is non-inferior to the standard treatment. And likely in cases like this, we would recommend additional studies. So a lot to think about with those. Of course, I'm happy to share these slides. I know it can take some time to digest all this information. And so when choosing that non-inferiority margin before your trial starts, it's obviously, a really important decision. It'll have implications for whether your results are considered to be superior, non-inferior, inferior, or inconclusive. So how do we choose that margin? So best practices typically involve using both statistical and clinical considerations. The statistical aspect usually involves reading through the literature and calculating a pooled effect size with 95% confidence intervals, if possible, from previous superiority randomized controlled trials that included your evidence-based standard treatment in a control group. And then you use clinical judgment, right? So deciding what we think is a reasonable fraction of that pooled effect size that we estimated from the literature. What is a reasonable fraction of that effect size that we think needs to be preserved by a new treatment in order for it to be considered non-inferior? There is a general rule of thumb that is used to set the margin at approximately 1/3 of the expected standard deviation of the outcome. Now, this one-size-fits-all approach might not always be the best, right? But it is used, frequently, but should be used, with some caution. And there are risks with this decision. If you have too large of a non-inferiority margin, risks include the possibility that you find non-inferiority of the new treatment when, in fact, the interventions actually perform quite differently. The risks of having too small a margin are that you could, number one, end up with an inconclusive result, or number two, you could find that the new treatment is inferior when in reality, it actually performs pretty similarly to the standard treatment. So deciding on the margin is, as I said at the beginning of this, maybe the most important decision that you'll make when designing one of these trials. So taking into account the seriousness of the outcome is recommended. So for example, if you're doing a non-inferiority trial where the outcome is morbidity or death, right? We likely want a smaller non-inferiority margin, given how serious the consequences are. If the outcome is distress, for example, like we have in some of our mental health studies, probably a slightly larger margin would be acceptable in those cases. But regardless of how the margin is decided upon, and this is something you can start doing as you read these papers, right, is to look for this. It's really important that you state in your work how you derived it. According to a review that was done, I thought was really interesting, over half of non-inferiority trials that are published do not provide a rationale for their non-inferiority margins, which is a serious flaw. So it's something for you to look for as you, if you get into this and read some of these types of studies. Okay, I think I'm a little bit behind on time, so I'll go through the last part quickly. But here, what I wanted to do is just kind of give you a case example of a very recent non-inferiority trial in Zambia featuring the SIDA intervention. That, as I mentioned, we've really just completed. This is very, very much hot off the press, as they say. Okay, so the basic setup for the trial was really based on two things. First, that compared to studies among adult populations, and I think you all maybe are familiar or know this already, compared to adult population studies, the evidence-based for interventions in global mental health for children and adolescents is much more limited, right? Most of the studies of the bigger interventions that you hear about, PM+, SIDA, et cetera, have been done with adults. The EASE intervention, of course, was focused on adolescents, and in some of the trials had some good results. In some of the trials, the results were not quite as promising as we had hoped, so kind of mixed results. So, part of the context for this trial is, bottom line, we need more of a focus and more research on youth populations. So that's one. And second, there has been this general movement in our field towards the remote delivery of interventions. This, of course, as you know, accelerated greatly during the COVID-19 pandemic, this need for remote psychotherapy. But despite this movement, there have been actually relatively few rigorous trials globally, especially in the global South, evaluating how effective remote delivered counseling really is in different contexts. So our trial featured CETA, the Common Elements Treatment Approach. You may be familiar with it. It's been tested in a number of places across the world, largely in the Global South. Is considered evidence-based for common mental health problems, including depression, anxiety, and PTSD among adults, I'll emphasize. CETA is based on principles of cognitive behavioral therapy, uses the traditional task shifting approach and an apprenticeship model of training and supervision. So it's delivered by lay providers with very little or often no previous background in mental health. It is designed as what they call a transdiagnostic treatment approach. It's meant to be equipped to address multiple potentially co-occurring problems. And so on the slide, you can sort of see the various therapeutic elements that make up CETA that the counselors are trained to choose from depending on a client's symptom presentation. The treatment typically lasts between 6 and 12 weekly sessions on average, but there is some flexibility built in there. So the intervention is meant to be personalized and tailored to a person's specific mental health needs. As I mentioned, it's been tested in a number of studies, mostly traditional superiority randomized controlled trials, also used in a number of programs around the world. Some highlights here. If you're interested in this intervention specifically, by the way, I'm also happy to send some papers along. In all these instances, CETA has been largely effective from a statistical significance perspective, typically with medium to large clinical effect sizes, compared to control conditions at improving the primary outcome in those studies. The primary outcome has ranged from depression to anxiety to PTSD to substance use to IPV, intimate partner violence. But as I mentioned earlier, the bulk of this research has been among adults. The one study done primarily among youth was in Ethiopia among Somali refugee youth. I highlighted that one there in yellow. That study was what we call an open trial or a quasi-experimental pre-post design in which there was no control group at all. So all the youth received CETA, and they did find that there were large within-group effect sizes for CETA from pre to post intervention. But again, that wasn't a fully powered, randomized controlled trial, which played a role in how we decided to design our non-inferiority trial. So again, motivation for the trial, number one, as I mentioned, strong CETA evidence for adults, promising evidence for youth, but much less evidence and from a weaker study design. Number two, in the past few years, the developers of CETA have created an adapted version of the intervention that can be delivered remotely by telephone called telephone CETA or T-CETA for short. But T-CETA has never been evaluated in an RCT in any population. As I mentioned, many of these remote interventions being used during COVID were really not rigorously evaluated. And so in some ways, this was, this was a classic non-inferiority setup. We have CETA, which has a strong evidence base. We have T-CETA, which is an experimental intervention that may be more cost-effective than in-person CETA, given that T-CETA is delivered remotely. And so we wanted to know, is T-CETA non-inferior to CETA in treating mental health problems among adolescents in Zambia? So we chose a three-arm non-inferiority trial design, CETA, T-CETA, and a treatment as usual, sort of no intervention control. And so as I discussed before, this is a more desirable scientific design than a two-arm non-inferiority trial. And we thought here that it was ethical and appropriate to do so in this instance because there hasn't yet been a full superiority RCT of CETA among adolescents before this one. So we had a sample size of 400 adolescents between 15 and 29 years old, and they were randomized to one of those three groups. And so this set us up to do three main comparisons, comparing CETA to treatment as usual control, comparing T-CETA to treatment as usual control, and then comparing T-CETA to CETA to see if it was non-inferior.
Dr. Ken, Dr. Ken, sorry. So would you be able to wrap up in a couple of minutes? Like we
Sorry,
are
yeah,
already.
for sure. I know I'm running behind. I have 3 minutes. I should be done. I only have like 2 or 3 slides left.
Yes, sure.
Okay, thanks. So we had 3 primary outcomes, PTSD, internalizing symptoms, which are things like depression, anxiety, externalizing behaviors like aggression. Our non-inferiority margin that we've talked a lot about today, we calculated using that rule of thumb that I mentioned earlier. So we used 1/3 of the standard deviation of our PTSD outcome. And then we evaluated outcomes at post-treatment and 6 months later. And we looked at treatment effects in the overall sample, but we also looked at treatment effects among those who we consider to be sort of higher severity, so those in the top 50% of baseline severity symptom scores. Okay, so we'll just go through the results and then we'll wrap. So you can see here a similar trend across 3 graphs and 3 outcomes. The red line represents the mean outcome scores for the control, treatment as usual. Black is T-CETA, blue is CETA. And so across all 3 outcomes, we found that both CETA and T-CETA were significantly superior to treatment as usual in reducing PTSD, externalizing and internalizing problems at both follow-up time points. In the overall sample, which is what these graphs are showing, we had medium to large effect sizes here for both CETA and T-CETA compared to that control condition. In the high severity subsamples, CETA, again, had medium to large effect sizes compared to treatment as usual control for all 3 outcomes. T-CETA had significant medium to large effects for internalizing and externalizing. However, T-CETA was not significantly superior to treatment as usual control for PTSD among the high severity PTSD subsample, right? So keep that in mind. Something else to note from the graphs, it's apparent here, right, that symptoms reduced to a greater degree in the CETA group, the blue line, than the T-CETA group, which was the black line. The question is, can we still consider T-CETA non-inferior to CETA? The answer is a bit of a mixed bag. So here's our version of the non-inferiority graph. You can see each line represents an effect size with a 95% confidence interval. Effect sizes to the right of 0 indicate a stronger result for T-CETA. Effect sizes to the left of 0 indicate a stronger result for CETA. You can see all effect sizes favored CETA over T-CETA. But you can see that in the overall study sample for the externalizing, internalizing, and PTSD outcomes, we have an effect size in a 95% confidence interval that is entirely within the margin of non-inferiority, that shaded region. So we were able to conclude that in this study, T-CETA was non-inferior to CETA for internalizing, externalizing, and PTSD in the overall sample. But in our high severity subsamples, here's what I was sort of talking about earlier. This is one of the things that can happen in these trials. We have this sort of dreaded inconclusive finding. You can see the 95% confidence intervals for those effect sizes overlap the margin of non-inferiority. So we were not able to make any definitive conclusion about whether T-CETA was non-inferior to CETA for these very kind of high risk, high severity subgroups. And this is my last slide, Benita, I promise. Just really quick conclusions and next steps. Again, this is all brand new. So we'd love feedback now or by email or follow-up calls or whatever. So we're still trying to figure out what these results mean ourselves. But first, both CETA and T-CETA were effective interventions for adolescents across internalizing, externalizing, and PTSD. In the overall population of adolescents, T-CETA seemed to perform about as well as CETA and could be an appropriate option, especially when in-person counseling is infeasible. But we need to be cautious about recommending T-CETA in high severity groups, particularly those with higher severity PTSD. And we really, I think, need more research to evaluate how well T-CETA can perform among those groups before fully recommending its use in those populations. I really apologize for going over, but hopefully that example gives you a bit of just a way to think about non-inferiority trials and something in a way that they can be applied to global mental health research. And I know that was a whole lot in a very short period of time, but I'm always happy to talk and have follow-up Zoom calls or answer emails for those of you who have questions. And thanks again to you guys for the invitation and for your attention.
Wonderful presentation, Dr. Kane. We have only 3 minutes left now, so let's move directly to
Sorry.
the questions, which is already in the chat box. So the first question is, how common is the non-inferiority design used to test psychological interventions?
Yeah, it's a great question. It's, it's not used that, I mean, it's used more commonly, I would say, in kind of domestic mental health research here in the US. And in global mental health, we haven't seen it used that much yet. And when you think about it, a lot of the global mental health studies that I just talked about have been done in the past 1 to 2 decades. So relatively, we're a bit of a new field, and I think still establishing the initial evidence base for things like PM plus and CETA and EASE and others. And so while we haven't seen too many of these yet, I would suspect going forward, now that we have a pretty strong evidence base for these interventions in our field, trying to find ways to make them shorter, to make them cheaper, and then testing those new versions in a non-inferiority trial against the more traditional versions, I think is going to become much more common. And so we're likely to see an increase in these, I would say for sure, over the next 5 to 10 years.
Okay, thank you, Dr. Kens. And the next question is, in the context of brief interventions, how would a non-inferiority trial be designed, especially if the treatment duration is significantly shorter than the standard? Additionally, how many weeks do you recommend as an ideal duration for such interventions?
Yeah, that's a longer, that would be a longer consideration. I mean, I think, you have some traditional people who design RCTs that say that it's really important that your two interventions you're testing against each other have the same sort of dose. And so if you're testing like a 1 session brief intervention versus a 6 session longer intervention, you can't really evaluate whether the content of those interventions is different unless you make sure the brief intervention has the same number of sessions. I disagree with that. I think that if what you're trying to test is something that's 1 session long, that's what you should test and not artificially increase it to make sure that the dose is the same as what you're testing it against. So I think you could probably, from my perspective at least, others may disagree, I think you could set up a non-inferiority RCT testing a brief intervention against a more traditional longer one, very similarly to how we talked about today. And I'd be happy to talk in more detail about that and advise whomever had that question if they're interested.
Thank you, Dr. Kane, and apologies to everyone that we are not able to get all the questions individually this time. So we will make sure to share the questions with Dr. Kane and get back to you with the materials and through the email as well. So thank you so much, everyone. Thank you so much, Dr. Kane, for your dedication and time for this webinar. We really understand that it's really difficult to cover all this content in this limited time frame, and it's somehow on us. That's our limitation as well. So beside that, it's a pleasure to hear your experiences on the content and the topic as well. And thank you so much, Ritika ma'am, Brandon, Nagendra sir. Thank you so much, everyone. See you in the next webinar and वेबिनारको रेजिस्ट्रेसन फर्म चाहिँ भरिदिनु होला हजुरहरूको यो क्वेसन चाहिँ हामीले मेटेरियलसँगै डाक्टर केनलाई पठाए पछाडि चाहिँ पठाउँछौँ रेकर्डिङहरू So thank you so much everyone.
Jeremy, thanks so much for doing that. That was incredibly helpful.
Yeah,
and
of course.
really,
I'm really sorry it took longer than I thought. But
no. It's
good.
a tremendous amount to cover, and it's and the educational part was, I think, super helpful for them. I mean, other folks can drop off and stuff, but just want to grab a minute of your time.
Yeah.
The findings are really interesting. Did you?
You're gonna see it in more detail, Brandon, when the paper comes the paper is coming your way. Whenever we actually get it. There's actually a close to ready draft for you and others to see. But yeah, the findings are interesting. I agree. Yeah.
Yeah, I guess it makes sense, right? I guess that in-person piece just needed for the higher level kind of
Yeah.
makes sense.
It kind of does make sense. Yeah. So I think they're super interesting. And we'll see, but especially for the trauma. And we did, there is the
Hmm.
qualitative, there was a qualitative component that we did where we asked people that we're still going, kind of sorting through those data too, kind of asking people what they preferred. And
Hmm.
most people really liked, I was really skeptical, by the way. I really thought that T-CETA, like doing therapy remotely in Zambia culturally would fail. I really
Yeah.
thought it was going to be a disaster. And it didn't, clearly. It actually worked, it seemed to work pretty well, which was a real surprise to me. But when we asked people in the qualitative in-depth interviews, if they liked the telephone theater, or if they would the telephone therapy, or they would have preferred in person, almost everybody says they would have preferred to have done it in person. And they said they kind of
Yeah.
put up with the T-CETA, and they said it was, it was fine. But it was interesting. Some people said, even if we could have one in-person meeting, like an initial in-person meeting with our counselor, like at the beginning of therapy, and then do the rest by phone. That would have made a big difference for us. I mean, again, like you look at the effect sizes and you look at a quantitative data, it looks like T-CETA did pretty well. But then when
Yeah.
you ask
Yeah.
people qualitatively, they were like, yeah, but yes, but I would have sort of preferred to have done this
Uh-huh.
in person.
It worked, but I'd rather see you in
It
person,
worked
which
better,
is
but
kind of like
yeah,
every meeting I
exactly.
have.
Yeah, exactly. Yeah, yeah. So there's definitely a lot to unpack. Um, so
So,
this is for those of you who are on, and Brandon was actually part of this study a long time ago when it was a totally different study. And then
yeah.
this was
Yeah.
the TTT, and then after COVID happened, the study fell apart basically. And we sort of we sort of salvaged it and redesigned and just came up with an entirely new different study design, which is what this
Mhm.
is than what we had proposed to do with that original one. But
Yeah, and just what one last quick point because I think this is so important. I just think about like places like Syria where almost everything has been done remotely because they can't kind of get people in there, and
yeah,
even if they're like so some of the most traumatized populations were relegated to using a lot of this remotely. So just yeah, is there a way to do some type of adjunctive in person in some way or things like that. So
right.
anyway, next steps would be super
Or
exciting.
next
Yes.
steps for sure. And also, and this is where, my expertise falls well short, but it's also like, is there something clinically that we can do, um, where like, for example, in Syria, where it really would be hard to do anything in person potentially, is there
Hmm.
some way to clinically alter or modify an intervention for those folks who have the more severe trauma and PTSD symptoms so that it's more helpful for them? Is there a way to modify the content of the intervention, a way to make that connection? And what is it about um, that population that makes the intervention somewhat less effective? And is there a way to remedy that? Trying to dive into that in situations where where any in person is really impossible,
Hmm.
would be an interesting next step, I think, too.
Cool. Well, so excited to have the results and excited to see the paper and then yeah, brainstorming
Yeah,
up stuff. Really
yeah, for
interesting.
sure. Yeah.
Cool. And
Thank you.
look forward to connecting about Ale's stuff. I went through all of her application
Yeah,
stuff.
thanks so much for doing that. Yeah, yeah. Oh, I know that she had such a great experience with you guys and with that with the MH
The
with
Jamie
MH Connect.
Connect stuff.
Yeah,
Yeah.
I mean she really raved about it, honestly. And so I think it was in some ways foundational experience for her. And so and her K is coming along very well. So I think
Yeah.
she's doing great.
Great. Well, Benita and Ritika, thanks for hanging on a little bit longer and all the coordination stuff. And huge thanks, Jeremy, for the
Yeah, of
morning
course.
arrival. And let's talk soon.
Yeah, happy to do this anytime. Thank you again for the invitation, guys. Really appreciate it. It was
Thank
fun.
you,
Okay.
everyone. Also,
Bye
huge
bye.
thanks to
I have
Logan
several questions.
Huge
I mean,
thanks to you.
let's say that
Sorry.
one.
Not just
I
listen,
have
login.
several questions.
Logan, thank you for the connection. This was a very beneficial webinar for all of us. Thank you so much.
Yeah. Thank you. Bye
Thank you
Thank you,
so
bye.
much,
everybody.
everyone. Bye
Nagendra,
bye.
Nagendra, we'll talk soon, okay?
Sure. Bye bye.
Okay. Bye, everybody.